Hi, Simon Smale, gastroenterologist in York. Today I'm going to talk a little bit about the role of drugs in the management of irritable bowel syndrome. I'm going to give a little bit of an overview, and then I'll perhaps either in this video or other videos go into a bit more detail about some of the specifics. So essentially drugs fall into 3 or 4 main categories in terms of things used to treat irritable bowel syndrome. There are drugs that affect the sensitivity of the gut. There are drugs that affect the motility of the gut. Drugs that affect the way the communication of the gut nerves interface with the spinal cord and the brain nerves, and vice versa. So a kind of feedback loop. And then there are drugs, or well, they're not actually drugs, there are foodstuffs and bugs which may have positive effects on the gut, and I'm going to deal with those in a completely separate video. So in terms of drugs that affect the sensitivity, things like peppermint oil may be useful, and essentially there are receptors for peppermint within the gut, and they may modulate some of the sensation within the gut. Essentially a peppermint receptor looks like a pain and temperature receptor under the electron microscope, and may have effects which modulate pain, perhaps, or distension within the gut. Drugs which affect motility. Now there are a range of drugs which affect motility. There are drugs, broadly speaking, which speed the gut up, things like domperidone, metoclopramide. Those are drugs which are less used these days because they have quite significant side effects. But one can also use laxatives, and one can use antidiarrheals, which obviously slow the gut down. Things like loperamide. Codeine not really recommended because it can lead to a problem with narcotic bowel syndrome and certainly with constipation. So starting with the antispasmodics, they reduce the contractility of the gut and therefore decrease the intensity of contractions and help soften the pain of the gut, within the gut, which is largely related to stretch within the gut wall. And then there are things such as loperamide, which one can use as antidiarrheals. That works by slowing the gut down and therefore giving the gut more time to absorb the water in the stools, therefore making the stools more solid and less likely to be giving you diarrhoea. One thing to mention is that a significant number of people with irritable bowel have a thing called bile salt malabsorption, and it may be worth trying cholestyramine or a drug called cholesevelam, which I can't say, in the context of bile salt diarrhoea, because that's often very effective, although not always nice to take. In terms of other drugs, obviously if people have got constipation, they may require laxatives, and whilst simple laxatives such as Movicol or Laxedo may be helpful, people shouldn't use stimulant laxatives long term, and people should try and avoid using lactulose because that often makes the bloating worse because it's a sugar and it tends to ferment within the large bowel. Similarly, people with irritable bowel syndrome should adjust the doses of those laxatives, ideally so that they're taking things on a fairly regular basis if they're people with predominant constipation, because what tends to happen otherwise, if you wait until you're very constipated and then you take a lot of aperients or laxatives, then you open your bowels and you get diarrhoea, then you don't take any for a few days and then you get bunged up again. And so you're better to try and get yourself on an even keel where you're perhaps taking a sachet of Movicol a day. Some people need up to 7 or 8 sachets a day, but you need to be taking it regularly rather than sporadically to try and get you on an even keel. So that's the drugs which tend to speed you up. The laxatives, in other words. There are 1 or 2 newer drugs which are used for people with constipation and irritable bowel. And of those, the one that's licensed for irritable bowel is linaclotide. And that's given for people who've already tried a number of agents for some time, often months or a year or more, before they move on to that. And that's sometimes effective in managing constipation, predominant IBS, and its associated pain for people who've got really unpleasant constipation. Obviously that needs follow-up, and it needs to be supervised by a doctor, because you'll need a repeat prescription, or you may need a repeat prescription depending on whether your bowel function has returned to normal whilst taking linaclotide. Lastly, of course, I mentioned drugs which have effects on the nervous processing, and the commonest one of those is a group of drugs called tricyclics, such as amitriptyline. The commonest side effect of those is that they tend to make you sleepy, so we often advise people to take them at night. In gastroenterology, we tend to take small doses of those. Conventionally in psychiatry, people have used perhaps 100 or 150 milligrams of amitriptyline. In gastroenterology, we usually recommend 10 milligrams, increasing up to 30 milligrams if benefit continues to be seen in increasing doses, but rarely do we exceed that dose. There are alternatives if need be, and there are a group of drugs called SSRIs which are sometimes used if amitriptyline hasn't worked. The evidence for SSRIs is probably slightly less good, but there's a reasonable scientific rationale for their use. Many of the drugs we use, however, have effects in a number of quarters, and it's not always clear whether they're having beneficial effects because they're speeding people up or slowing people down. So, for example, amitriptyline does slow the gut down, as well as having effects on the nervous processing within the spinal cord, we believe. So that's a brief overview of the kind of drugs which are used in IBS. There are some other drugs which I haven't mentioned, which are in rather more research related use. However, those are the ones that form the mainstay of treatment. I hope that's been of some help. Thanks for listening.